Hello again, my name's Dee Campbell, I'm a coding educator, and welcome to today's video about diabetes, CKD, chronic heart failure, and hypertension. This is going to be a longer video about all these different conditions. They're all very important here, but I hope everyone will take away a good understanding about it. Here are WITH guidelines. We're just going to breeze through it really quickly and assume everyone has a good understanding of how WITH guidelines work. If you don't, please watch my video of WITH. Just remember, WITH just simply means any association at all. It doesn't necessarily mean due to or associated with. It also means a presumed causal relationship and unknown linkage of two WITH conditions. Let's start out with CKD, the easiest codes to work with. CKD, whenever you have it, just make certain you code it to the highest stage possible. Providers, make certain you're clearly documenting the stage in your notes. As you can see, CKD is honestly the easiest one of these codes for all coders to code. As long as your documentation's good, all coders should probably have these memorized, because as you can see, they're really easy. It's N18.2. If it's stage 2, I know just type in N18 and then the stage. We then have the code first guidelines for CKD, that whenever there is a patient with CKD, we must always use the with version of diabetes, where it'll be with diabetes and CKD, which is the .22 version of all of these diabetes codes. Hypertensive heart disease, we will have to use those combination codes whenever we have a patient with CKD and hypertension. If you don't use the proper combination codes, you will have denials. Heart failure, as you can see, is quite a bit larger of a category and where coders tend to struggle. So providers, please document very thoroughly what kind of heart failures the patient has, so in that way your coders can assign the highest level. It's broken down into each of the different types of failure, and then whether or not it's acute or chronic. It's actually pretty easy to work with, but a lot of coders have a tough time with these, honestly including me, if the notes aren't the greatest. So make certain you let us know whether or not it's chronic, which kind of heart failure it is, so that way we can assign the highest level possible. Hypertension, I have broken down into just a list form like this, and then I have some infographics as well for each different learning style. Hypertension has this, this mouse wheel is really sensitive. Hypertension has these use additional guidelines. Whenever you have a patient who has hypertension, make certain you indicate their tobacco status if possible. Whether or not it's exposure or history of it for the patient, but just make certain for tobacco, a lot of these will conflict with each other. For F17, these are current tobacco dependency, so if you have it with a history of dependency, you will have denials, so just make certain you report it to the highest level possible. And then hypertension is broken down to each of these families, where we have hypertension with different heart diseases, hypertension with CKD, or hypertension with heart failure and chronic kidney disease. And then finally, I want to point out one of the newer hypertension codes, resistant hypertension. This is more or less a status code, so it's always important to indicate which kind of hypertension the patient actually has that's being resistant, if possible. Here's a table version of each of the information. It looks like quite a bit, but honestly it's not too much if we break it down. This is just for hypertension here. So at the top here we have all the different hypertension codes and guidelines for it. So hypertension will be broken down like so. And then we have the I-50 codes down here for reference for when you're using your chronic heart failure codes. We have our CKD codes here, and then we have our WITH guidelines here. So basically you just follow the table for if the patient has hypertension and just heart disease, then you'll use one of these I codes here. If it's the hypertension with CKD, then you'll use this. If it's both, then you'll use one of these. And that's pretty much it. That's how you'll report hypertension. As we know, hypertension is one of the most common conditions in America. I think, 48% of males have it, and 42% of females have it. So if you're not reporting your hypertension right, the likelihoods of having denials is very high. A key thing that'll help a lot of providers to make certain you're assigning the right diagnosis is stupidly how it's written in ICD-10 is they're not exactly the same. So I always suggest that you just search Hyper10. If you search Hyper10, then you will get all the Hyper10 codes, because the other ones are hypertensive. So if you just search hypertension every single time, you're not going to find the more appropriate higher level codes. In the recent ICD-10 expansion, though, they added more for the I50 codes for when it's CKD without heart failure. So it's actually really nice that they spelt it out for us now, that all of these I51 codes are the ones that are going to trigger the I11s without heart failure. Because truly, these codes weren't reported that often, the without heart failure, because there wasn't much guidelines on this. But luckily, in the newest ICD-10 guidelines, I've made this infograph of it for us that makes it easy to work at. What kind of stinks about the guideline change, though, that's worth noting, is if a patient does actually have chronic heart failure, then some of these will exclude now. So, for example, if you report cardiomegaly with chronic heart failure with heart failure, it will deny it because now cardiomegaly is considered a part of without heart failure, so it kind of gets denied for the whole Intragold guidelines. So just watch out for that. But hey, at least now we actually have a way to use these codes more often. Here's a little infograph for the secondary hypertension codes. This is one of the main times that I have seen as a coder when CKD is actually truly separated from the hypertension, is because it's secondary hypertension. But I've never actually seen it where it's appropriate to use I10 hypertension with CKD. And then once again, for resistant hypertension, just make certain you're reporting the other ones with it if possible. I have this little guideline here for hypertensive crisis, where it's a table broken down for the ICD-10 guidelines for which code gets reported for when a hypertensive crisis happens. Let's say the note says, is the hypertensive crisis diagnosis definitive and certain? Yes, it is definitive. Then we must review the medical record, and then we must code to the highest specificity based off the documentation. So let's say it says hypertensive urgency, you will use hypertensive urgency. If it says emergency, use emergency. Unknown, use the crisis. And that's how we will code for hypertension. Next, I have diabetes here with the width broken down by the individual families here. How diabetes works is we have the width conditions in individual pockets for some of the more common ones, and then there's also the other specified where you'll find like hyperglycemia or skin conditions. What I would like to point out first of all for diabetes is there's the width ones, and then the .9 ending for every diabetes code is without complications. So just remember, if you ever report like an E11.9 with any of these other complication codes, you will get a denial each and every time because it's conflicting information. I have a table like this to review for how it works, and then I also made a grid for how it works. Diabetes is very important, so I just wanted to give multiple options for how each different brain type works. But basically how our diabetes will work is the first 3 characters is where we'll find the type of diabetes. Next, for the 4th characters is where we'll find the width guidelines, and then I have it broken down by color coding for where it would go. For with or without coma, for this cases, a very common one you'll see is E11.2 with kidney functions, and then we'll go into with CKD. It's as easy as that. If a patient has polyneuropathy, I will go into the purple circulatory, and then I get the 2. So I get E11.5.2. And that's how we're going to report diabetes. We always report it to the highest characters possible. Here's another way that you can view it, where it's all the different codes are broken down. This is kind of how I started with diabetes coding to make it easier for myself. And then here are the more specific ones. So with other specified gets broken down into a lot of categories, and then the eye conditions get broken down very greatly too. So I have each of those in their own individual tables for whichever way you prefer to learn. So let's say we have a patient who presents Whereas type 2, they have an arm ulcer and a foot ulcer, and they're type 2 diabetic. I would code that as E11 type 2 with a .6 with skin complication, followed by with a foot ulcer and with other skin ulcer. And then if another coder reported this with the E11.9, the without complication version, you will get denied. On diabetes in remission, this code recently got added just as of last year, I think it was. However, it's not the greatest code in its current existence. This code was more or less made because, as you may or may not know, a lot of patients on GLP-1s, they get their A1C so low that insurance then tends to deny their GLP-1s, and it becomes this huge mess. So people are trying to come up with a way to actually report diabetes in remission, because it's actually happening with GLP-1s now. However, the current definition of this code is it's the patient without medicine for at least 3 months. So it's actually not applicable for that GLP-1 scenario, but a lot of people are arguing about this right now, so hopefully, knock on wood, in the next year or so, in another update or so, I can make a new video saying, yay, diabetes and remission guidelines have been updated. But until then, no, it means without medicine. Next, let's discuss code also. Code also is a very important guideline in ICD-10 reporting, where a lot of codes will have explicitly next to it code also. For diabetes, we have the code also for the medicines that a patient takes. The reason for this is you must report the medicine that a patient's on, so that way all reports and all payers can know whether or not this patient is being treated with, let's say, insulin, or if they're being treated with insulin and metformin, or if they're on a combination of insulin, metformin, and a GLP-1. So here's a table for how each of the main most common diabetes codes will work. As you'll see, type 2 diabetes, E11, has the use additional meds. E09, diabetes due to drugs, has this guideline here as well. And diabetes due to underlying condition also has the use additional medicine codes. Type 1 diabetes, as you can see though, it does not have that guideline. The reason for this is because a type 1 diabetic is obviously going to be on insulin. They're obviously going to be on other meds, so it's redundant to report the medicine. However, a patient with an acquired diabetes all can go through different situations for how they're being treated. So that's why it's very important that you report these med codes for each of your diabetics. Otherwise, what's going to happen is, let's say you report E11.42, type 2 diabetic with polyneuropathy, and then you don't report any med codes with it. What you are indicating to all payers and insurance and any reporters who are going to view your information is your patient's being purely treated through diet and exercise exclusively. Obviously, that doesn't look good. So that's why it's important that we report to the highest level possible each and every time for our diabetic patients, so that way you as the provider will also look like you're doing the proper thing for your patient. So make certain you report the diabetes medicine each and every single time you're dealing with the patient with acquired diabetes. And as you can see, each of these have the excluded notes where they obviously exclude each other. You can't report multiple type diabetes for a single patient. So a type 2 diabetes cannot be reported with a type 1 diabetes. So what about type 1.5 then, D? Well, guidelines for type 1.5 is pretty clear that one was actually going to fall under the other specified diabetes E13. A recent letter from the APAC issued that yes, for diabetes type 1.5 LADA, we will use the E13 codes. So just remember that we will use the E13 codes for whenever we have a type 1.5 patient. You do not want to indicate both type 1 and type 2. That's just going to look silly and it's going to cause denials. Make certain you use the E13 in those situations. And finally, And actually, before we wrap that up, I want to go to drug-induced again really quickly. Drug-induced, whenever you're reporting a drug-induced diabetes, make certain you always report a T36 through T50 code for that patient that indicates what drug caused their diabetes. You'll have to report this on each and every visit. I do have a video on drug-induced conditions. Please watch that video if you're uncertain about it. And then due to underlying conditions, make certain to code first the underlying condition. Usually cancer is going to be the main one that I see most often. And yeah, that's about it for those conditions. And then finally, what I have to wrap this up with is encounter for screening codes. Never ever use the Z13 code when you have a patient that is actually diabetic, they actually have CKD, or they actually have chronic heart failure, when you're ordering any labs to monitor those conditions. So what I mean by that is an obvious one is to report a Z13.1 diabetes. Screening with a diabetic is going to be silly, it's pointless, and it's just going to cause denials. If you're uncertain about the screening guidelines and ordering to the highest level, please watch my video on ordering screening labs. My name's D. Campbell. This is my video on hypertension, diabetes, and CKD. And you can see they're really not that hard once you break it all down. Just make certain you understand with guidelines and you're always reporting diabetes to the highest level possible. And then make certain you're always reporting your medicine with it. And then for hypertension, just make certain if you ever have any of these other conditions with the hypertension that you always code to the highest level hypertension code, or you will have denials. My name's D. Campbell. Thanks for watching one of my videos.